Hello, everybody. Sorry about being late. Can you hear me very well, participants? I believe they can. Is that correct? Okay. We'll be talking about Walter Mmeka, consultant medical oncologist. We'll be talking about emergencies in oncology. Okay. Emergencies in oncology is one area of interest, which do we really have actual emergency in oncology? But there are emergencies because if you don't address them, the mortality, morbidity can be very high. So that's why it's very crucial to understand emergencies in oncology. The learning objectives today, we will be looking at to discuss the major classifications and subclassifications of oncological emergencies, discuss signs and symptoms and treatment of each emergency group. So it promises to be very interesting. So what is an oncologic emergency? Is any condition of any sort resulting in either metabolic derangements like hypocalcemia or hyperkalemia or neurologic cardiovascular involvement like cord compression, or...
They said they can't see the slides.
They can't see the slides.
Yeah.
They can't see.
Yeah.
Okay. Stop sharing. You're sharing your screen. I can't even move this thing to.
I think now they can see.
Can they see it now?
Yeah. They can see it here in my share.
Okay. Can they see the slides? Okay. So I can go ahead. Is that correct? Okay. So anything cardiovascular, hematologic, like neutropenia, infectious disease changes and all that, by cancer or, due to treatments, complications due to treatment that requires, immediate intervention, So is described as an emergency, okay? So getting on top of it is very, very crucial in terms of how far we go. Can you make sure they are seeing the slides? Check with them.
I can see the slides in my laptop because I'm logged in.
Okay. All right. So emergencies in oncology are very common. Many patients with cancer present with acute illness. And so usually it doesn't come to the specialist. They do not come to the specialist. They come more to the generalist. And who are the generalists, if I have to bracket them there? It could be the general physician on call, A&E doctors, GPs, IMT trainees, senior house officers, registrars, and all that, or even ACPs. So those will be the people looking at these patients and seeing them first rather than the specialist. So you have to be very careful there because at that point, you need to be very mindful of gathering information, gathering information from these patients and making appropriate decision in the setting of an emergency. You need to find out during your history, is there a previous diagnosis of malignancy? Are symptoms due to tumor or complications related to treatment? What are the, what are the patient's previous treatments? It's always good to link up, find out, what treatment do they have, because you may have to ring the oncology team on call. So it's very important. How quickly are their symptoms progressing? Like in cord compression, you may find out that in cord compression, after 48 hours or 24 hours, you might not be able to change the game with radiotherapy or surgical decompression in case that was needed at the time, and also steroids intervention. So the timing of the symptoms, the neurologic deterioration is very crucial. Otherwise, we may not achieve much. And also, even when they are neutropenic, most chemotherapeutic agents by day 9 to 10, they are neutropenic, So you need to know when last was the chemotherapy, and now patient is in A&E at day 9, day 10. So it's very crucial to know these landmarks, okay? Interval time between treatment and onset of the symptoms, and also your approach Could it be directed treating the malignancy or the complication? Because sometimes if you had small cell lung cancer with superior vena cava obstruction, you may have to treat them with chemotherapy alone and the obstruction will relieve. So, so those are, exceptional cases where you have to treat the malignancy and then, the patients get better in the setting of emergency. And what are the patient's other existing medical conditions? It's always very good to put on your medical hats when you're dealing with an oncology patient. Very, very crucial. They have MI in the past, they have strokes in the past, they could have an AF, they could have so much going on in the past. So you need to bring everything into perspective for very good decision making. Great. So the four main groups that we'll be talking about here today is, we just divided the emergencies into four main groups, all right? And you could see CNS problems involving brain metastasis spread to the brain or meningitis to the brain or spinal cord compression, one group. Another group is people with bone marrow related problems, which might even be disease related with marrow infiltration, or it could be treatment related like neutropenic fever, febrile neutropenia, sepsis and all that. And then it could be due to acute metabolic disturbances like hypercalcaemia, or tumor lysis syndrome. So these are things that could happen and cause metabolic derangement and present as an emergency. Or it could be in the form of blockages, blockages, superior vena cava obstruction, as I've said, or cardiac tamponage. So those are the four broad groups that we'll be looking at. Okay, let's start with the brain group. So brain metastasis is very common with lung, breast, melanoma, and a couple of other cancers less common in, ovarian, testes, GI, and all that. So it's very good to understand the epidemiology of this and the incidence. So what do we do? Brain mets should be imagined in two ways, Firstly, you need to ask yourself, is this solitary or diffused brain metastasis? Like this is diffused brain metastasis, and this other film is solitary. How are you going to approach these slides or these patients are very much different, okay? So firstly, as a doctor on call, on duty, in whatever department you find yourself, brain mets confirmed, the next best thing to do, start them on steroids. Start them on steroids, okay? And then if it's solitary, the next best thing to do is to seek neurosurgical opinion or refer to brain mets MDT, which we have, okay? So that's the next best thing. If it's solitary, refer to brain mets. And sometimes it's quite oligometastatic. A few dotted lesions sitting in one area, you may have to consult neurosurgery as well, because sometimes we could do stereotactic radiation or we could do debulking surgery if they're very close by. So solitary and oligometastatic brain lesions, please get neurosurgery brain mets opinion, all right? And again, if it's now metastatic, like this diffused metastatic multiple brain mets, again, start your steroids and consult oncology for radiotherapy, okay? Radiotherapy, sometimes, steroid does most of the job. Steroids can reduce vasogenic edema by as much as 60% and improve symptoms in these patients. Because if you don't intervene early with steroids, should they have midline shift, patients could cone and could collapse and die before you know it. So other interventions could be radiotherapy to the brain, whole brain, or stereotactic. As I've said, stereotactic would be for oligometastatic, 2 or 3 lesions sitting around the same region. But you just contact neurosurgery if you're not sure what's going on. And of course, sometimes we treat them with chemotherapy alone in the setting of small cell lung cancer. So if it's small cell, if you've gotten an opinion, the patient is small cell, sometimes we treat them and the brain mets improves as well with chemotherapy alone. So you could see, there's a lot of approach to the management of brain metastasis. So the first question is to ask yourself, is it multiple or is it solitary? If it's solitary brain mets, as you see here, if it's a young, fit male, most, I wouldn't say we discriminate against elderly, but some of them may not be able to handle the kind of surgery you're talking about, They may not be fit with a lot of comorbidities. And it depends on the type of cancer as well. So if they were young and fit, oftentimes we could do surgical debulking for solitary mets, We've done it in testicular cancers that got very good survival benefits and stuff like that, and even some types of lung cancer as well. And brain, it's done. So you just consult oncologists and get brain mets MDT, okay? They could have a long disease-free interval, okay? Long disease-free interval. And sometimes it could be done for some tumors that are radio-resistant, radiotherapy resistant, like renal cancers and all that. Great, so that's the management approach. So in summary, young fit patients get surgical opinion on brain mets MDT. Again, start them on steroids. Everybody should be started on steroids. You don't have to wait. Start them on steroids. Okay. So with frequency we've talked about could be greater even in clinical life. Autopsy could report as much as 60% of cancer patients having disseminated or, brain metastasis of some sort, maybe single or multiple. Sometimes it could be very difficult to distinguish from primary brain tumors. So particularly when the primary is not known. But you leave all that, we will figure it out. The main aim today is to be able to manage and know what to do when you found a patient in the A&E or in the ward with brain metastasis, or through your acute medical units. They could present with headache. There may be no headache. There could be focal neurology, seizures and stuff like that, or it could still be subtle changes that may not be too gross. It could be with vomiting as well, or incontinence, if it's frontal lobes at times. So sometimes it's very subtle. But in a cancer patient with headache and vomiting or seizures, please get a CT brain as early as possible as a baseline. So CT brain is the primary investigation of choice. Sometimes the radiology may want to go with a non-contrast in case that was a stroke, but usually a contrast is better. And then once a hemorrhagic stroke is ruled out. MRI is very crucial at times for cancer patients, not only to delineate the lesions properly, but it also is able to bring out cerebellar lesions, and CT brain will not be able to delineate cerebellar lesions, okay? So that's why MRI might be crucial to identify the extent of the disease. Biopsy is rarely necessary, but sometimes you never say never in medicine. You could come to a situation where it doesn't look like what it is, There are a couple of differentials which I cannot go into because of time. That's Cryptococcus neoformans, which again, serology can identify. Sometimes toxoplasmosis could form as a differential as well, which serology can identify. Those involved with cats and things like that. Sometimes it could be a lymphoma spots from HIV, and sometimes we don't know, then we're sticking a needle. Right, but it's very rare, very rare, very rare. Great. Now, brain metastasis can also affect the spinal axis, So we treat when you've got, cranial metastasis or spinal metastasis or carcinomatous meningitis, okay, following the spinal cord and things like that, and the CSF fluid. We treat this group with chemotherapy, intrathecal chemotherapy, but I wouldn't want to go into this. I'll leave this for some of you that are excited to come into oncology as a specialty. All right. But you could get a lot of carcinomatous meningitis from non-Hodgkin's lymphoma, breast, lung, ovary, and melanoma. And, mortality can be quite high too if we don't intervene. But I wouldn't go into a lot of the treatment options because, we'll leave it for more niche oncology group. Great. So we're making progress. Spinal cord compression again falls into the CNS group of oncology emergencies, okay? So most commonly extradural metastasis with direct tumor extension from spinal bone metastasis are commonly caused by, it may present commonly with vertebral collapse or you seeing lytic lesions or osteoblastic lesions spread out on the spine, most common in breast, prostate, and lung cancer. Okay, so just for a bit of anatomy there, you begin to see the cord, and you could see some cord swelling, and that's the tumor there in the collapsed vertebral body. And you could see some bone edema because of compression. You could see the CSF fluid and the spinal cord itself. I hope this diagram is quite clear. You could see the indentation of the cord by the tumor there. Okay, that looks around T12 or so, okay, or T10, okay? So you could see that. So that's spinal cord compression, okay? And this is somewhere again in the thoracic spine, T8, about the T8 region again, you can see. Thoracic spinal cord compression can be quite common in about 60 to 80% of patients. So 3 to 5 patients presenting, 3 out of 5 patients presenting, it could be locking around in the thoracic spine. All right, there you can see the tumor indenting the spinal cord there. All right, and they could present with neurologic deficits of various degrees. This is again an image of cord compression in the lower lumbar spine. So you could see there, so that's L5, S1, 5, L4. So that's L4 there, okay? So that's L4 malignant cord compression, also L3 involving, okay? So because you should be able to appreciate these images too on straight call, before you call your registrars or your registrars are there, you should be able to see the image and, get official reports and then begin to act. So what are you going to do after all of this? Well, this is just a bar chart. Let's just run through this quickly, showing the incidents. This was actually done in Aberdeen, Scotland, where I did some training and specialist work as well. So you see that this was published in the Royal College of Physicians of Edinburgh Journal. The commonest presentation for spinal cord compression in 58 patients in Aberdeen Royal Infirmary. We begin to see prostate, lung, breast, GI cancers, tailing down there, bladder, adrenal, carcinoid, gynae cancers, malignancy. So you can see the spectrum, but prostate, lung, breast as constant stars, okay? So when you have a patient with prostate cancer, leg weakness, or neurologic deficits or pain, have a high index suspicion that this could be what it is, called compression, okay? Great. So rapid diagnosis is very crucial, very vital to preserve neurologic function. Very, very crucial. In fact, after 24, if not 48 hours at best, you may have lost preserving neurologic function. So it's very crucial to take your history and intervene as early as possible in order to aim to preserve neurologic function. So this is just a little multiple choice, for those of you going for MRCP and other types of exam, it's saying signs, symptoms of cord compression within 24 hours or less. Back pain, weakness, autonomic dysfunction, sensory loss, usually with a sensory level, or ataxia. Okay. Which of this is the most common, if I want to ask? Which of these symptoms do you think will be most common, or if not most common, but it tells you on a high index that this patient has a cord compression? I can hear from the audience. You can unmute yourself if somebody wants to tell me what he thinks. Which one do you think has the highest level to tell you that this is cord compression? Anybody else? Can I hear them? The audience?
Autonomic dysfunction.
Autonomic dysfunction, you think? Very good. Any other person?
I think it's autonomic dysfunction.
You think is autonomic dysfunction. Okay. Well, the answer is sensory loss. Sensory loss. Sensory loss, usually with a demonstrable sensory level, has a high index suspicion that this is cord compression. High index suspicion. Back pain, you know yourself. These are elderly bunch. Pain is always a constant star with degenerative disease and all that, you know. So you may not, it may be non-specific, okay, but it could be an early sign. But don't be thrown away every time with back pain and all that, okay? Weakness, again, could be a deceptive sign, okay? You know, these guys could be hospitalized for long. They've got proximal myopathy. Even at home, they've been lying in bed and the daughter is raising alarm. Oh, he can't walk anymore. It could be proximal myopathy from disuse over time or prolonged hospitalization or even weakness due to age. So it could be deceptive. But when it's unilateral weakness, the index suspicion starts to get up as well, okay? That is lost function in one leg, you know? It shows index suspicion is higher, all right? Autonomic dysfunction, which is urinary bladder incontinence, again, it may not really, yes, it may help to localize that it's around the T10 because the bladder is about T10 level, but it's not, it doesn't still, I mean, you could be incontinent because you're unwell. You could be incontinent because you're just moribund, just flat out, isn't it? Mm. You could be incontinent even with medication overdose. They could be on morphine at home and stuff like that. You know, so, you know, general debilitation could make somebody incontinence, you know, severe sepsis and all that. But yes, autonomic dysfunction could localize at times if somebody is conscious and alert, you know, and it helps you to tell you the level, which again goes to your sensory level. So sensory level localizing oftentimes tells you that this high index could be cord compression. So that's why the answer is sensory level loss, your L3, L4, L5, or S1. Ataxia, quite non-specific, but sometimes it could tell you that this could be cerebellar. So it could tell you that cerebellar brain mets. But again, these chaps could be chronic alcoholics, you know, at home. You're already at toxic gates. Their gates are not steady, so you could be misled from that. And they could be on medications as well, you know, or Parkinson's and stuff like that. So it may not really localize for you or give you the high index suspicion. So sensory loss, usually with a demonstrable sensory level, has the high index to predict that you may be dealing with cord compression. But the rest are helpful, but it's just for you to know. You know yourself as you go and write your MRCP exam, that's best of 5, isn't it? Every answer looks the same. All right. And this is one of your questions. Great. So differentiating between cord compression itself and cauda equina is very important. So you can label your patients properly and say, oh, he's got cord or he's got cauda equina. Where does the cord stop? Where does the cord stop itself? L1, L3, L4, or L5?
No. L1.
L1. So you see the cord ends around L1 and just a bit of flicking out around L3, L4. Okay? So anything below that, L3, L4 down below, you're talking cauda equina. Cauda equina syndrome. So the presentation could be a bit different. You see the cord could come with hyperreflexia, spastic paralysis, and extensor plantar, and you can demonstrate your spinal level if it's within the cord easily. You can localize to the thigh, you know, or to the lower, you know, abdomen area, L2, L3, and all that, the groin or the side. You can localize if it's touching the cord. But for cauda equina, you could get absent reflexes. That could be flaccid paralysis, fasciculations, flexor plantar, and, you know, dermatolar loss as well. That could be scattered. So these are just little differentials, okay? But again, your MRI will help you as well to tell you, you're seeing something around L5 or S1, and then there's some, you know, non-specific things. It is likely to be a cauda equina syndrome, you know, the horse tail. Great. So what are we going to do? How do we investigate cord compression? X-ray is readily available for those who've got back pain anyway, but it's not very sensitive. So you don't want to waste your time on that. But yes, if it's non-specific, you can still call for, X-ray of the lower spine, lumbar spine. Bone scans, not very helpful. They're only just going to show you spots due to metastatic disease. And sometimes the degenerative changes, you cannot discriminate with metastatic disease with a bone scan. So it's not going to help you much. It's just going to show you a spot around there. It's not going to delineate properly. Rarely do we do myelography anymore. I say it's totally outmoded by now. So the investigation of choice is MRI whole spine, okay? So that's what you click. MRI whole spine, taking it through the neck down to the sacrum, okay? MRI whole spine is the investigation of choice. Right, so what are you going to do immediately you've got a cord compression? You don't need to wait for anybody once it's confirmed. Even with your radiologic eyes that we learned about those anatomies, you're seeing it is compressing, okay? Start the patient on dexamethasone steroids as soon as possible, okay? So the standard dose we do here is either 16 milligrams straight off once a day, or you can fractionate it to 8 milligrams twice a day. All right. There's an initial study by the Americans that looked at 96 milligrams, but it was prone with a lot of toxicity. And the outcomes were not too exciting that we helped those on 16 milligrams. So 16 milligrams, dose level for steroids is enough to begin to reduce vasogenic edema and reverse those neurologic compromise that you get from the thicker and the thicker sac and the dorsal horn. All right, so steroids. So once you've done this, then you're now thinking again like you did in the brain mets. The thinking is it solitary? If it's a solitary brain mets, then you're getting the patient discussed at the spinal mets MDT or getting the surgeons involved early. Get the surgeons involved early once it's solitary, because surgical decompression is the gold standard. And it has been shown that people can recover and start working. But if you miss that window, as I said, you got 24, 48 hours because you are just faffing around, waiting for things. And you're going to become a wasted exercise. You will not have changed the game. So have a very high index suspicion. Timing is very crucial. Start the steroids, get onto the surgeons for solitary metastasis, okay, solitary deposits to the spine. Then after that, surgical decompression, we do radiotherapy after, okay? And then for chemotherapies like small cell lung cancer as well, sometimes we start to treat with chemotherapy and then do radiotherapy later and maybe decompress, And sometimes they are not well enough, fit enough. He's 89, 88, demented. No, he's in bed most of the time. You're not going to change much, even if you found cord compression, You're not going to change much. So best supportive care could be an option. And of course, rehabilitation and stuff like that, okay? You have to rehabilitate them after you've treated them properly, get them back to physio, and the protocol. There's a protocol for cord compression. It's all in the ward. So the nurses know about that, okay? They should be put on the cord compression protocol. Great. So for multiple metastases, what do you do? Multiple spinal mets, and that's caused a compression. So clearly, it's very daft to go and be decompressing one area when you have multiple mets. Do you know what I mean? It's not going to change the game. Some centers may try to for some young patients, but it doesn't make technical sense really. But the first thing to do again, steroids for multiple meds. Then the maximal area of compression referred for radiotherapy. So radiotherapy, if it's done pretty early, will change the game. Remember, we have an acute oncology service. We can get MRI very quickly, okay? If you have a high index suspicion, okay? Once it's a known cancer patient, you will come into our pathway, our spinal cord compression pathway quickly and as soon as possible. So we can get the MRI straight off, but you should have started steroids at your point of care. All right, and refer and contact appropriately, okay, the relevant disciplines. Okay, so multiple meds, steroids treats the maximal area, okay, with radiotherapy, okay. Sometimes you could reverse it through with radiotherapy, but a bit tricky. Great. So we've finished with the CNS form of emergencies, okay? We finished with the CNS form of emergency, and I hope you picked up a few things there. Right, so hypercalcemia comes into the metabolic disorders, the commonest metabolic disorder we see. The other metabolic disorders like sodium, potassium, sodium, potassium, magnesium, and, you name it, a couple of them, phosphates and things. But hypercalcemia remains our commonest metabolic, something you want to concern about, okay? Great stuff. Great stuff, okay? I could have asked a multiple choice question here, but I'll put it up in my next slide, okay? And that is if I said, which of these blood chemistry is the most fatal to cause damage and harm with a high mortality? Hypocalcemia, hypercalcemia, hyperkalemia, hyponatremia. Anybody? So which of them do you think can be very lethal if you don't address? Hypocalcemia, hypercalcemia, hyperkalemia, hypokalemia, or hyponatremia?
Hyperkalemia.
You think is what?
Hyperkalemia.
You think is hyperkalemia? Anybody from the audience or from the people online? Anybody want to take a guess? Okay, nobody's sticking out their head. It's a tricky one, but sometimes the college accepts hypocalcemia because you know yourself, when you go hyperkalemia, you have to cardioprotect your heart first by using calcium gluconate, isn't it? Because your heart will go into, arrest, because the heart will go into tetany quickly. So hypocalcemia can be very dangerous at critical levels. The rest, hyperkalemia, you can always get around them. Hypokalemia, you can always correct, but when they are low, they can just, all right? So I think sometimes the college, we just put an answer to find out what people think, okay? Great. So raised calcium from bone destruction, really from disease, inadequate bone response to replenish that as well leads to further destruction, and also paracrine activators, and sometimes they could be mediated through parathyroid-related protein, PTH-related protein as a paraneoplastic syndrome to cause hypercalcemia. Sometimes we have screened for parathyroid-related protein when, hypercalcemia is becoming refractory and uncontrollable, You could get it in small cell cancers at times, So we can screen if calcium is very refractory. So common again in breast myeloma, also in prostate and disseminated cancer. Symptoms or signs or metabolic effects, you get polyuria, sodium depletion, secondary increase in renal tubular calcium reabsorption, and this could damage your kidneys as well. So nausea, reduced conscious level, reduced oral intake. This combines to exacerbate hypercalcemia. So symptoms, anorexia, it can switch off your appetite because the whole viscera is tight, splashing vessels are all tight, So the absorption capacity is reduced, so it switches off your ability to eat. Nausea, vomiting, constipation can arise because of that. Confusion, polyuria, thirst, drinking a lot, bone pain, as we call it, and coma can resolve. So there's this little mnemonic for many years called CAMS. So you get constipation, anorexia, muscle weakness, polyuria, polydipsia. And when it's so bad chronically, you could get stones for those that are stone prone. And when those patients, they react very badly with abdominal cramps. They cramp a lot. They groan, they moan, as we call them, if you leave them in A&E. You know, the hypercalcemia can treat them really badly, you know, really, really badly. Bone pain, abdominal pain, they are moaning, it's a hellish situation for them. So think about stones developing in this stage for these patients. Right. And at times there might be no symptoms. All right. At times there might be no symptoms, unfortunately. There might be no symptoms. So it's good to know that the hypercalcemia, at times there could be no symptoms. All right. Great. I'm not going to go into how to correct your calcium. It's already in the blood, but those days we train, sometimes you need to correct calcium yourself, you know, through this calculation. But it's still obtainable for some of you if you wanted to learn it. But in the interest of time, we'll just go on. So what do? Somebody has hypercalcemia 3.5, okay, and it's multiple myeloma, or rather, we're not sure what the patient's diagnosis is, but he had a lot of lytic lesion in the bones and presented with the A&E. Are you going to start requesting for bone scan, myeloma screen, or are you going to hydrate patients straight away, or are you going to request for serum immunoglobulins? Okay, there are lytic lesions all over on x-rays and things, and now there's hypercalcemia 3.5. What are you going to do? 3.5 falls in the severe range. What are you going to do? You know, it's hydration. So the next immediate thing is hydration. It's not about going to request for myeloma electrophoresis and all that. The next best thing, hydrate patients, okay? So infuse at least 4 liters. In fact, it depends. You can even go straight on bang on because you need a form of forced saline diuresis in a way. Forced saline diuresis. So you need a lot of fluid, a lot, especially in the first 4 hours, I'll say. Okay? Maybe 2 hours, then 2 hours, then you can now play around because you need to get it out as soon as possible. The more you hydrate patients, you're able to lower the calcium. Okay? So while hydration is going on, please watch for overload because some of these patients could have cardiac-related problems. So that will be at your discretion how you run your fluid. Okay? But you still know that you've got a choice to do something else. You can get on with furosemide. Do you know? Furosemide is also there, is calciuric. If they've got heart failure and things, and you are, don't be doing 12 hours for this group, please. Don't be doing 12 hours, 16 hours chart of fluids, okay? So give them a generous amount of fluid, all right? And you can offload the rest with furosemide, okay? 40 milligrams, which is also calciuric, okay? Or if you don't want to be aggressive, you could use some thiazides, but they are slower. So these are emergency. Furosemide, I'll say, is the drug of choice there, okay? And of course, you now begin to get your bisphosphonates for this group of patients, okay? Bisphosphonates, zoledronic acid or palmidronates or your alendronates, palmidronates, okay? 60 to 90 milligrams, okay? For refractory patients, especially patients with sometimes sarcoidosis, sarcoidosis could present with hypercalcemia. Steroids could be a good treatment there. And for refractory hypercalcemia, we've tried steroids permissibly, sometimes with effect, sometimes with no luck. Those are the group you want to screen them for parathyroid-related protein peptide, okay? Calcitonin and metramycin are literally outdated. I wouldn't get into that, okay? You get it in medullary thyroid cancers. It's very rare, very rare, very rare. Okay, but today we've got licenses for, apart from zoledronic acid and palmidronates, we can also explore denosumab, okay? But you need to get to oncology. Denosumab is a rank line guide anti-calcium agent, okay? It's an oral supplement. So for refractory hypercalcemia, we can use denosumab. But I didn't, apart from daily slides around that. Another metabolic derangement which can be common is tumor lysis syndrome. Tumor lysis syndrome. What is tumor lysis syndrome? It's actually a time-bound definition. Tumor lysis syndrome is not when somebody has had chemotherapy and is coming after 2 weeks or 3 weeks or 14 days. No. It's after someone has had chemotherapy and is presenting in A&E literally within the first 3 days. You get this in cancers like lymphoma, leukemias, buckets and things, small cell cancers, neuroendocrine tumors. These cancers can melt with treatments by about 80% reduction. So you just shatter the cells in the blood. So the breakdown products are so much that it can cause metabolic and morbid conditions for the patients. Okay, it's characterized by hyperkalemia, hyperuricemia, uric acid from breakdown of tissues, purine and pyrimidines, hypocalcemia, and hyperphosphatemia. So you see this in your blood. Sometimes hyperphosphatemia may not have shown up, or hypocalcemia may not have, but you're seeing hyperkalemia will be very early. Hyperkalemia, you're going to find it early in the blood, okay? As well as hyperuricemia. So it can lead to renal failure. That's why it's an emergency. And then you lose your kidneys, you're stuck. And of course, it can cause arrhythmias. I mean, there's a host of a lot of things, it can cause arrhythmias to the heart, renal failure, and all that. So it can be quite dangerous. You could flip into AF, and then you're going to the ICU because you are treated only 2-3 days away. So it's a time-dependent definition within the first 48 to 72 hours presenting into A&E. That's what tumor lysis syndrome is. So somebody coming in after the 12, the 5, 6, 7, very unlikely. Okay, very unlikely. They will, if it's going to happen, it should have happened. Great. So how do you prevent this? Again, hydration. There's also allopurinol you can use for those renal impairments or kidney-related issues. Sometimes rasburicase can be an option, rasburicase. So aggressive hydration again, sometimes alkalization of urine, these are optional. I don't want to go into that. Just start hydrating, and then your seniors can take it over from there. And of course, standard management of hyperkalemia protocol, okay, which you all know, okay? You know your standard hyperkalemia management protocol, okay? And in extremis, they may need renal replacement or filtration or dialysis. Great. Question time just to wake us up. Anybody wants to tell me what are the features or signs of in the blood for tumor lysis syndrome? Anybody? Anybody from?
Hyperphosphatemia.
So you're saying it's B. Are you saying it's B? Are you saying it's B?
Yeah.
Okay. All right. Okay. Let's see. Correct. So hyperkalemia, hyperuricemia, and hyperphosphatemia. Very good. Very good. Okay. So management of neutropenia. So now we've left the metabolic group. So we've done 2 emergencies now. We've done 2 emergencies. Are we happy with the explanation so far with the 2 groups I've talked about? Are we happy? Let me hear from the audience.
I had a question.
Yes.
For the dexamethasone, is it the same dose for brain metastasis and spinal cord compression? It's the
Yes.
same dose?
Yes. 8 milligrams BD or 16 milligrams is fine. Okay.
Yeah, thank you.
That's a good question. Yes. Any other question before we go into the 3rd emergency, which is neutropenic sepsis and febrile neutropenia and all that?
I'm sorry,
any
a quick question. Yes, for
Yeah.
dexamethasone, is there any preference for IV over oral, or is it the same? And
Good
no
question.
concerns really.
Good question. It depends on patient circumstances, If they were vomiting and not able to tolerate, then IV route is okay, All right. And, if there's if they were nauseous or feeling sickish, depending on where you find your patients, or they had infection, urinary tract and stuff like that, you go IV, okay? But oral, if they are able to tolerate, okay? Depends on where you find your patients, all right?
Thank you.
Okay, any other questions?
In hypercalcemia, how long do we need to wait before giving the bisphosphonate?
Very good. So bisphosphonates can be, bisphosphonates can be given on the same day. In fact, it depends on whether it's mild, moderate, or severe. For mild hypercalcemia, you don't need bisphosphonates. IV fluids, furosemide can do the job. For severe hypercalcemia, then you have to give zoledronic acid or palmindronate on the same day as you're doing it. All right? Okay?
Yeah.
And you don't repeat it again because why? The half-life is 28 days and they are renotoxic. So you don't want to use it twice, please. We've seen it happen in the wards. Don't give it twice because the clearance is long, okay? Consult the oncology team or specialist team. We know what we do. I told you about denosumab, which is more renal-friendly. So we could walk around or try steroids, okay? And it takes about 2 to 3 days for you to see an appreciable fall in your calcium. So you need to be patient, all right? 2 to 3 days, okay? Any other question before we move on to the the sepsis part of it?
Oh, yes, please, actually. Could I ask, you said tumor lysis syndrome, that
Yes.
can happen spontaneously as well, right?
That can what?
Without spontaneously, so without chemotherapy, someone can go into tumor lysis syndrome?
Okay, well, that's quite interesting, really,
Oh, sorry.
Tumor lysis syndrome is something given with chemotherapy, okay? So it's the chemotherapy that causes the lysis of the tumor, all right? So it's very magical to get a spontaneous type of tumor lysis, all right? So it's usually precipitated or provocated by cytotoxic agents, all right? Yes, so the tumor is breaking down because you're treating them with chemotherapy and they are breaking down very fast. So it saturates the whole place with uric acid and pyrimidine and purine breakdown. So those things concentrate as uric acid and hyperuricemia. All right.
Yes, sorry. I saw one of our patients on oncology, but it wasn't here. It was when I was foundation. And to be fair, she didn't have chemo, but she was very unwell. And she had a high-grade cancer. I can't remember what it was. It was a hematological cancer. But we thought she went into spontaneous tumor lysis, but I might be wrong because she didn't have any chemo.
Yes. Okay. Well, sometimes the autoimmune processes could be somebody on graft versus host disease and things, autoimmune processes whereby, your immunity starts to break down the cells too fast, okay? So, sometimes when you are in training or coming around training, you're not getting the gist of what is happening, all right? But the definition is post-cancer chemotherapy, okay?
Thank you very much.
We understand it, yeah. Any other question before we get into this now, the febrile neutropenia? Okay, so let's get on with it because I didn't start early. Okay, but I hope we are having fun. Are we having fun? Are you getting the gist of the day? Okay. All right, so let's go into management of febrile neutropenia. These are more based on European guidelines, really, with the UK adopted as well. So it's more broad-based, okay? So basically, febrile neutropenia is defined as an oral temperature of greater than 38 degrees. I wouldn't worry about the 0.3 there, 38 or 2 consecutive readings of 38 degrees for 2 hours, okay? So, you measured first is 38.3. Wow, that's high. You measure again and it's 38 in a space of 2 hours, okay? And the patient had chemotherapy or something like that, okay? So that is febrile neutropenia, or an absolute neutrophil count less than 0.5 post-chemotherapy. That is neutropenia. Or if you're expecting something to fall, probably you got 1, but patient was febrile, you should have an high index, okay? All right, to bring them in or manage at home conservatively with prophylaxis. We'll talk about those approaches. So again, neutropenic fever or myelosuppression can come from bone marrow being replaced by tumor. You must understand that. And how are you going to know? Does anybody want to tell me, how would you know that the marrow is replaced by tumor? What are the simplest ways to know that the cancer has spread to the tumor? We've got HB. HB is now 7 or 8. Platelets are down at 62 or 51, and the neutrophils are 0.7. What is the simplest way to know that this could be marrow infiltration? Does anybody know? Pardon?
biopsy.
So somebody's saying a biopsy. Any other person? It's a blood film. You should request for a blood film. And what is the blood film going to tell you? Does anybody know when you've got malignant infiltration of the bone marrow? Does anybody know? So you're going to find leukoerythroblastic picture where you get a mixture of immature white cells and red cells. So it's called leukoerythroblastic film. So a blood film should be requested where you're seeing all like a pancytopenia, okay, post chemotherapy. You should get a blood film because the tumor may have gone into the marrow, and that often portends a very poor prognosis. All right, portends a very poor prognosis. So treatment-related complications post-chemotherapy could be acute following cycles of treatment. Sometimes that could be chronic as well from extensive exposure to cytotoxic. So again, just to stamp that definition again, febrile neutropenia, 38.3 or 2 consecutive readings greater than 38 or absolute newts less than 0.5. So risk factors, age. The older you are, there's a risk of myelodysplasia or myelodysplastic syndrome, where the marrow will have burnt out. So you need to understand that. You need to understand that. And it could be from advanced disease as well, advanced disease, history of febrile neutropenia previously, or no antibiotic prophylaxis or GCSF use. Now, we don't encourage GCSF use inadvertently. You must have a certain criteria with your chemotherapy for us to advise GCSF use. Mucositis or poor performance status patients or patients with cardiovascular disease. So these are risk factors to note. There's what we call the MASC febrile neutropenia risk index score. It's good that you familiarize yourself with it, sometimes you could find them in A&Es and in the wards as well. So the MASC febrile neutropenia risk index score looks at the burden of illness. Is it little or nothing or mild symptoms? A patient scores 5, and if it's moderate, patient scores 3. If the illness is severe, they score 0. If the patient is hypotensive, but if the blood pressure is very good, they score a higher mark. Okay, or they have pulmonary disease or no pulmonary disease, or solid tumors like fungal infections with no history, or their hydration status, or outpatient onset of fever. So if they have an outpatient onset, that's, the score, outpatient status at onset of fever, and age less than 60 years old. So that's the MASC scoring. Patients should score above 21 to be low risk. Below 21, you want to classify them as high risk. So again, that's an algorithm there, 38 degrees, newts 0.5. You need prompt assessment, vigorous resuscitation if needed, okay? Calculate MASC score if you can, but otherwise, you already see the patient in front of you in the active setting. Get on with it, okay? Start them on broad spectrum antibiotics on intravenous, preferably, okay, for high risk patients. For low risk patients, you can admit them as inpatient. You could still start, some very low risk patients that are okay. Maybe they are watching Manchester United match at home. You could advise them to watch at times. Okay, if they are low risk and you've spoken to them, they are fine, but temperature they just spark 38 because there are other differentials of raised temperature, especially in the cancer patients. 1, it could be their disease. 2, it could be a clot. 3, it could be simple dehydration. 4, it could be temperature, external temperature. It was very hot a few days ago, wasn't it? So it could be temperature, it could be certain things, okay? And it could be a lot of inflammatory cascade going on in the body, if you know what I mean. So causing the temperature to spike. So you can still treat some low-risk patient at home. You could give them prophylactics with ciprofloxacin. They don't need to come in, but you need to be very sure with your assessments, okay? For high risk, get them in, start antibiotics as soon as possible, okay? So we use this algorithm for those who's had chemotherapy. So when you come into oncology, you'll understand this better. Febrile neutropenia risk greater than 20%, we start them on GCSF. It's not everybody you see the A&E with neutropenia, you should start on GCSF, okay? It's a natural response to have the neutrophils dropping, natural response. Most patients on chemotherapy by day 9, day 10, their neutrophils could drop. So it's not a new excitement, all right? In fact, it shows they are doing well, but it's a complication of treatment, all right? So day 9 is the nadir. You'll be asked, for those of you doing exam, day 9. That's the nadir where you expect neutropenia. So for high-risk patients, greater than 20% with the chemotherapy, we start them on GCSF, okay? If it's less than 10%, we don't start them on GCSF. We just assess them, okay? And then factors like age and things and the risk between 10 to 20%, we look at them, other comorbidities, we may want to start them on GCSF, okay? But if the whole thing is not less than 20%, not really, you don't need to. And if you don't know what to do, ring the oncologist, ring the oncology team than for you taking a decision to start them on GCSF, inadvertently. Okay, so these are recommendations. Febrile neutropenia we see in about 20 to 30% of our patients, and it can carry a mortality up to 10%. And GCSF use can be quite effective in the high-risk group patients with febrile neutropenia greater than 20%. That's from their chemotherapy. You leave that to us. Patients with febrile neutropenia should be assessed for risk complications using validated tools like MAS score. And also low-risk complications can often be treated with oral antibiotics and possibly as outpatients, okay? So not everybody that should thump into hospital because they are neutropenic, because they come in on low risk. You could reward them with CBM, or you could reward them with MRSA. What a shame, So it's not everybody because they are neutropenic. And so what? Neutrophil is 0.9. They are watching a football match. They've got a temperature, but they are fine. They don't need to come in. All right? They don't need to come in, all right? Great. Okay, so this is the CTC, common toxicity criteria for grading neutropenia. So starting from grade 4 there, as you can see, is life-threatening, neutropenia less than 5, greater than 24 hours. This one should come straight into hospital. Grade 3, neutrophils 0.5 to 0.9. Again, severe, they should be in hospital as well. Then moderate group as well, 1 to 1.4. You don't need to do anything there. It doesn't mean that, don't panic, 1 to 1.4. Don't panic again for grade 1, 1.5 to 1.9. But what you can do from grade 2 to 3, start to watch the trend, whether it's going down or whether it's going up if they came into hospital. Because sometimes if they had treatment, they may not have reached the nadir. Nadir could also span from 9 to 14 days. So the patient is feeling unwell because something is happening. So you could check their neutrophils. They came in 1.2 and the next day, boom, is 0.5. Okay, so you watch a trend if they came into hospital even with moderate neutropenia but feeling unwell. There could be other things going on. All right, great. So neutropenic arise from bacterial organisms normally present in the hosts. Again, most patients may have a PICC line or Hickman line. So those could be source of your sepsis. Inspect all of this. Sometimes you may find suppurative abscesses around the margins of the PICC line, skin contaminants as well, or central lines. Specific organisms can be isolated or brushed or swabbed. You do your septic workup on these patients, okay? So long-standing neutropenia, when we start to treat neutropenia, we start with standard antibiotics. When things are not going well, we have a high index suspicion that this could be fungal, this could be viral or parasitic, but that is the trend. The first thing is to start with bacterial because that's the commonest one. And the major risk of death is from gram-negative septicemia. You must know that, okay? Great. So fever, sometimes there is no fever because our patients are not able to mount immune response post-chemotherapy. So don't be expecting a fever for you to think somebody is septic. Sometimes they are not able to mount a temperature response, and yet they are not feeling well. Okay, there could be non-specific symptoms of malaria, anorexia, even nausea or vomiting. All right, so temperature is 38, you know, or even 37.5, feeling funny too. It can be very tricky. Then, you know, check for localizing features, because it could be urinary tract or it could be COPD exacerbation as well, if they had COPD for cough, or pneumonia brewing, either community acquired or hospital acquired. Look for the bad signs, okay? Hypotension, very dangerous, oliguria, bad signs. It will intervene quickly on these patients, otherwise you're going to lose them, because by the mass criteria, they go into high risk group, okay? So of course, your basic workup, get your temperature, blood pressure stuff, FBC, blood culture, swaps and things if you need them, and chemistry, okay? But it's good to do your blood culture on baseline for anybody 38 anyway. Who knows the yield of blood cultures in the general medical practice? How often have your blood cultures helped you? What percentage? Does anybody want to tell me? What percentage of blood cultures have come back positive and are useful in clinical practice? 10%, 20%, 30%, 40%, 5%.
20%.
Anybody else? Please, I want to hear from the audience. What percentage of blood culture have been positive that are useful to you? Anybody? Okay, 20%. 20%, about 1 in 5. Why am I saying this? Because sometimes blood culture is going to come back negative, and yet you're still dealing with a problem, okay? Isn't it? And I know that's what you say in practice. You're still treating them on antibiotics, but yet they are not feeling well, and blood culture is coming back negative after 48 hours. All right? So you must know that. Okay, it's not every time it's going to be great. So treatment for oncology, if they came in unwell, depending on mild, moderate symptoms, you can start with tazocine. Why do we use tazocine? Because it's gram positive, gram negative, and it has activity against, does anybody know?
Atypical.
Against?
Atypical.
No, not atypical. There's an organism called Pseudomonas. Pseudomonas aeruginosa, and Pseudomonas is a hospital-acquired infection. What are hospital-acquired infection? Yes, Pseudomonas, E. coli, Klebsiella, Shigella, and Staph epididymis. So these are common hospital-acquired infections, which tazocine will cover, you know. All right. So even we doctors, when we are old, you find out that most of our lungs may be colonized by Pseudomonas and all the bugs because we've been in hospital. So we're going to have a hospital-acquired infection because we've been in hospital for long. So tazocine is a drug of choice. And even for chronic COPD, from them you start with tazocine at times, apart from your basic antibiotics of amoxicillin and all that. So if they were mild moderate, tazocine is fine. But if they were very unwell, you are not very happy, you better start them on gentamicin. Or you could leave a note if you don't want to slam them on too many antibiotics. You say start tazocine for sure. If patient spikes, what do you do? Add gentamicin, okay? So it's a decent way. It shows you are a good doctor, you know, because when you saw the patient, you didn't think he was so moribund or unwell. So you started with tazocine. So because you know the principle of antibiotic use, the less, the better, the narrower the spectrum, the better, isn't it? Okay, you don't want to just use too many because before you know, you reward them with CDF, MRSA, and all the bugs in the world. So you could do that, okay? So gentamicin if you're being worried, okay? No harm. If they're in renal failure, what would you do? Anybody, what would you do? They are now in renal failure, or they came in renal failure, and they are neutropenic. Anybody want to tell me something? Palayani Vikaswarna.
Hiya, sorry. Is the question if they're in renal failure and they come in with neutropenic sepsis?
Yes, what would be your drug of choice?
Oh,
Your antibiotic of choice. Or what would you do differently? Remember, we talked about the two common drugs, but now you've got a situation where there are renal failure.
I guess you could renal dose it. So you could give a renal dose of the drugs.
So what is the renal dose? What is the renal dose of tazocine?
I would check the guide. I'm sorry, I don't remember.
Okay, does anybody know the renal dose of tazocine? Because you see, in an emergency, sometimes it's not a time to check. You have to be a professional. That's one of the outcomes of this, you people learning these things, you know? It's not a time to be running about. Even the nurse hanging around you knows what to do because she's been seeing it all the time. So anybody that knows that, anybody from the floor there?
BD instead of
Yes, BD dosing, okay? Twice dosing instead of QID, okay? So now you got him on tazocine, but you're still worried that with renal failure, there's hypotension, patient is unstable still. What drug are you going to use? Are you going?
Cephalosporin.
Cephalosporins, you know, it doesn't solve your problem because you already have him on broad spectrum tazocine. Remember, gram-negative cover is your fear. And now you want to bail away from gentamicin, isn't it? So what are you going to do? Anybody? So the drug of choice there is, you could try ciprofloxacin. They are renal friendly. So you could add tazocine BD plus ciprofloxacin. So you got your gram-negative cover because ciprofloxacin is very gram-negative, effective, okay? Right, so we're making progress there, okay? So that's what you do in those situations. If they were pen allergic, what, anybody wants to tell me what you're going to do if they were penicillin allergic?
To type of planning.
You could use the astronams, okay? There are guidelines, astronam. They are penicillin, but the reaction rate is about 1 in 300. Your cephalosporin is about 1 in 10 chance, 10% risk of cross reactivity, okay? Cephalosporins. So the best thing is your meropenem or your astronam or stuff like that if they are pen allergic. And sometimes you can use your clarithromycin if you're worried about atypicals, okay? Atypical infections like mycoplasma and all that, okay? So those are, because the choice of antibiotics too when you're in emergency is important, okay? And let's say they had a pig client that was infected with Staph aureus. What do you think would be the choice of antibiotics? Your PICC line or your Hickman line, you saw
Vancomycin.
Vancomycin is a good choice. Let's say they were vancomycin allergic. What would be your choice?
Tetracycline.
Oh, thycoplanine. All right. So these are basic things that will help you as physicians, you know, when you're on a ward round, because you guys are seeing them at first port of call, isn't it? So, okay, he's allergic and your residents are asking you, what do you do? Put him on thycoplanine. All right. Okay. Put him on thycoplanine if they were vanc allergic. Great. That's for staph infections. And review 48 hours. If no fever, they are doing well, doing brightly. Downstage them to oral antibiotics and try and discharge them to over the next day or two. Okay. All right. Great. You guys will be great physicians, really. Right. So neutropenic infections, treat and change your oral after 48 hours or 72 hours based on response. Again, your microbiologist is always there to talk to, but you know, you have to, the guidelines are there, but if you don't know your onions, you'll be moved, swayed left, right, and center, and you may not respond appropriately in the state of emergency, okay? All right? You're not going to blame your microbiologist if you made an error, isn't it? You're not going to blame. That's why you have to learn these things. If it's refractory in the first week or so, consider antifungals, antivirals, and anti-PCP. All right? All right? Good. What is the treatment of PCP or PCJ? Pneumocystis jirovecii. What's the treatment of choice? What's the antibiotic? What's the drug of choice? Cotramoxazole, yes. And of course, antifungals, we've got ambisone, We've got, we've got a few of them, okay, in that class, but I don't want to go into that because of time. Okay, so that's a little about neutropenic fever, neutropenic sepsis, and all that, febrile neutropenia. Any question, because that is very common clinical scenario you will meet. Any question before we go into the blockages, which is the last group of emergency? Any question from the floor? Any question from the floor? So does it mean it was well understood? Before I go into blockages, do you have any questions concerning febrile neutropenia, antibiotics use, and all that?
No, it's clear now. Thanks.
It's clear. Okay, very good. I'd like to hear from another doctor there. Is it clear, or as a comment before I move forward to this? Anybody else? Okay, like everybody's excited there. Okay. All right, very good, very good. Okay, neutropenia. Okay. Can you use steroids in the setting of neutropenic sepsis? Can you use steroids? What if they were having hypotension? It's entering septic shock. Can you use steroid? Anybody from the floor there online? Can you use steroids when they are entering hypotension? Yes, you can. They're entering gram-negative shock. You need your steroids, okay? So it's not an absolute contraindication. You can use them, all right? Okay, very good. So that's fine. So let's move on with the obstruction now. So we've done the kind of three groups of emergencies. We've learned about the CNS type of emergencies. We've learned about the metabolic derangements. We've learned about the infective causes, okay, which is neutropenia, okay, and also cancer-related infiltration. And I also have to diagnose these patients, all right? Now, the next group are obstruction. Superior vena cava obstruction we see commonly, where mediastinal tumors like lung cancer, lymphomas, germ cell tumors, breast cancer cause physical compression, sometimes with thrombus as well in the SVC. Patients could present with dyspnea, stridor, dysphagia, facial swelling, neck, arm swelling, headache, venous distension. There's a sign that they use for testing for thoracic inlet syndrome or outlet syndrome. Who knows the sign? Where you ask the patient to raise their hand up and then they may feel fainty. I can't remember the sign now, but it's good to know for your MRCP, okay? For your MRCP, it's good to know the sign. I've forgotten the name of the sign, but you can check that up, the Trousseau sign or something. Okay, so these are the symptoms you get, and signs you get. Sometimes they are not all complete, and yet you've got a picture. Can you hear me very well? Can you all hear me very well online?
Yes,
we can hear you.
Very good, okay. Okay, so it could look like this, all right? It could look like this, okay? And chest X-ray may look like this with the mediastinum all blown out, all right? And then this is SVCO angiography. This is a radiology thing at times when you're trying to find clots and things. If you can't find anything on chest X-ray, they may want to cannulate it and really trace where it's kinked or something. So what's the management? Again, steroids. Start with your 16 milligrams. You've seen the patient's skin and anterior chest wall with tortuous vessels up and down. Patient is very dyspneic and very, literally choking from his SVCO. Start steroids. Now, there are times where chemotherapy can come in after that. Small cell lung cancer, lymphomas, teratoma, contact oncology. If it's a small cell, chemotherapy can melt those things away and the patient is free. You know, it just clears them up in the next few days on starting treatment, okay? Then there's radiotherapy again for non-small cell cancer to the breast. So if it's due to non-small cell cancer or breast cancer and other cancers, we can do radiotherapy to the superior vena cava mass, and that will melt it, and then you get some decongestion of the SVC. Or maybe after chemotherapy failure for small cells and lymphomas, we can still do radiotherapy, all right? And interventional radiology comes in at times, maybe to stents, and if it's so bad, a kink, and there's a stricturing segment and vascular. But I wouldn't want to bother you with that. Just start them on steroids, contact oncology, okay? All right? Then we'll take it from there. But you must know that radiotherapy is an option or chemotherapy. The role of anticoagulation is not defined, okay? All right? It's not defined. So anybody preferably from the floor, which is not a symptom of superior vena cava obstruction. For those of you online, I want to hear you, okay? Just tell me it's A, B, C, D. I'll be waiting. Anybody? Ahmed Sheikh, do you want to tell me?
I think it's C.
You
It's
think
both
C?
lower extremities.
Okay, anybody else? Anybody else? C, very good. It shows people are listening. All right, so we're doing well. So when you see that, you know, please, when you see all those signs, just keep acting, start them on steroids, you know, get the necessary investigations and get oncology on board, okay? And don't go fiddling around with anticoagulation at times, you know? Okay, although they can have a prophylaxis dose of being in hospital. Cardiac tamponade, not very common, but we do see it where there's a lot of effusion into the
Cardiac tamponade presence.
Yes,
With
yes. So it's not often we see it, but sometimes post-chemotherapy, people could have effluence into the pericardium. So we get cardiology and, you know, we do fenestration for them. X-ray may show you enlarged hearts and raised JVP. Sometimes heart sounds are quiet as well. ECG, because you are getting fluid around the pericardium, you're getting small complexes with your, you know, because the ECG is not able to contract effectively to, you know, you got fluid around it, so you get small complexes. Okay, so treatment, aspirations, get the surgeons in cardiothoracic and all that, okay? I'll treat the underlying cause. Very good. Okay. Now, feedback. Any questions? Let's start with any questions so far? Any questions? Any questions so far? Be it neutropenia, be it cord compression, anything you have asked me? Any questions? This is your hour, this is your time, you know? Okay, if no question, I would like to get a feedback. How was the session? Starting from you there.
Quite
Yeah.
good, actually.
Huh?
It's quite good, actually.
It's quite good. What was quite good about it?
I mean, a lot of variety of topics, and yeah, so you need this, day to day.
It was quite clear and concise
It is.
and clinical. Is that?
Yeah.
Okay, then from the online folks, yes, let's hear from the online folks. What were your feedbacks? Feel free, feel free. Ahmed, let's hear you, Ahmed Sheikh.
Very structured and organized. Thank you.
Okay, Mustafa, well done. So structures and organized. And did you learn something?
It
I
was
think
really
a lot.
clinically orientated, so that was good because these are the cases we usually find on the acute takes, especially neutrophilic sepsis and
Very
neutropenic
good.
sepsis. So yeah, that was helpful.
That was helpful. Okay. And now you'll be more alert with your use of antibiotics as well, isn't it?
Yeah, definitely.
Yes. Okay. Yes, you can use your microbiologist, but at least you should have some basic knowledge, because otherwise you are totally a lame physician. Do you know what I mean? You're a lame physician every time. All right. Very good. Okay. All right. Any other feedback? Were the questions helpful? The small multiple choices? Were they helpful? They were quite helpful. Okay, very good. All right. Well, in the absence of no question, I think we've done well. 15:45. Started a bit late, you know. All right.
Yeah.
All
that's
right.
fine.
How many people online there? Very low.
It's going as well. Yeah.
Okay. All right. Okay. That's fine. So I should disengage the slides then. Is that correct?
Yeah.
Yeah, it should come in. Okay. Okay, bye. Thank you for your audience. Okay.
Thank you.
Thank you. Thank you. Thank you, Mustafa. Thank you, Kalayani Vishwan. Okay. Okay, bye.
Thank you. Bye.
Bye, bye, bye.